whole class period tomorrow doing some cases, and then we'll also do some other practice questions that are not case-based to get more experience with the antimicrobials. So as you've seen throughout the course so far, different antibiotics and antifungals have come up numerous times as causing a drug interaction with the other classes of medications that you've discussed. So for today, we're going to talk about antimicrobials relatively comprehensively. So we'll talk about them in two different ways. So most of what we've talked about so far, definitely in my lectures, and I think in most of your others as well, we've talked about the primary drug as the object drug, and then the interacting drug or the precipitant drug is what causes that interaction or causes the change to the object drug. So we're going to talk about that with antimicrobials, but we'll also talk about, revisit some of the instances where the antimicrobials are the precipitant drug that's causing the interaction with the different object drugs. So you'll see it structured a little bit differently. And some of these interactions you will have seen previously because the antibiotics are what's causing the interaction, but I wanted to review them again today so that we have everything with the antimicrobials together in the same material. So we'll have a fair amount of material to cover today, a lot of different interactions that we'll discuss, and then we'll try to summarize it all together at the end. So these are all of the different specific agents and classes of antimicrobials that we'll talk about today. It is not comprehensive. There are some others that do exist, but that are less commonly used, so we're not going to go into as much detail with them. We'll talk about these antimicrobials that are used more frequently and have more significant interactions. Because there is a lot of material, I've tried to highlight some things that are particularly important. So as we go through the slides, things that are highlighted in red should be a clue that this is probably an important interaction. That doesn't mean that things that are not in red are things that you won't see again, but the things that are in red are try to draw your attention to things that are particularly important to remember. So you should see red text either in the title of the slide or in some particular parts of the slide throughout the presentation, and that should draw your attention to that material. So we'll start with beta-lactams, and we'll talk about penicillin, cephalosporins, and carbapenems. So overall, there are fewer drug-drug interactions with beta-lactams compared to some of our other classes of antibiotics. But with the beta-lactams, there are some specific interactions between specific agents in each of the class. So they're not necessarily class-wide interactions like we'll see with some of our other antibiotics. So for penicillins, there are 4 primary interactions that are listed here. And you'll see that each of them are with different precipitant penicillin. So it's not class-wide across all the penicillins. Some of these, so the first one with oral contraceptives, this could be a class-wide effect. It's been most clearly documented with amoxicillin and ampicillin, which is why they're listed here, but it's something that you want to think about with any penicillins. So these penicillins can cause oral contraceptives to be less effective, which could result in menstrual irregularities and very rarely unintended pregnancy. So whenever a patient on oral contraceptive is prescribed with penicillin, they should be counseled to use an alternative form of contraception during the course of the antibiotics and for 1 cycle after completing the antibiotics. Amoxicillin and piperacillin have been shown to interact with methotrexate. This is particularly with the high doses of methotrexate that are used to treat cancer. Methotrexate is used in lower doses for other indications, and the interaction does not appear to be significant then, but when it's used in high cancer doses, then penicillins can inhibit the renal tubular secretion of methotrexate, and this results in increased toxicity. And the primary forms of toxicity that you'll see are bone marrow suppression and GI toxicity, so nausea, vomiting, diarrhea. The next interaction is with mycophenolate. So we've seen this before when we talked about immunosuppressants, right? So we know that mycophenolate mofetil is hydrolyzed to mycophenolic acid, which is the active metabolite of mycophenolate. And the mycophenolic acid is then metabolized to an inactive metabolite through glucuronidation. And in enterohepatic recirculation, there are enzymes that convert the inactive metabolite back to mycophenolic acid, the active metabolite that's reabsorbed, so we have more of the active product. And we saw that some antibiotics, amoxicillin is the penicillin that's been specifically implicated in this interaction. So these antibiotics can prevent that enzyme from converting the inactive metabolite back to the active metabolite. So this will reduce the serum level of mycophenolic acid, the MPA. So we'll have reduced levels and reduced efficacy of mycophenolate. So again, amoxicillin is the penicillin that's been specifically demonstrated to have this interaction. Other penicillins could have the same effect, but it hasn't been demonstrated in studies. A major interaction is with warfarin. So dicoxicillin and nafcillin have 2C9 induction. So this will cause a reduced INR, reduced anticoagulant effect of warfarin, so you may need a higher dose. The induction of 2C9 is a gradual process, so it can take 1 to 2 weeks of having this interaction to see the full reduction in INR with warfarin. And similarly, once the antibiotics are discontinued, it can take some time for that effect to fully wear off. So the time period that you'll need to be monitoring INR more closely with warfarin is extended. So you'll need to monitor it initially, and just because you have if you check an INR, 3 or 4 days after starting dicoxicillin, for example, you may not see a big change, but a week later, you may see a drastic reduction in the INR. So you have to be pretty vigilant in monitoring INR closely for an extended period with this interaction when both starting and discontinuing the antibiotics. So these are the main interactions with penicillins. The next we'll talk about are cephalosporins. So not all cephalosporins, but some agents in this class have an interaction with gastric alkalinizers, so antacids, histamine receptor antagonists, and proton pump inhibitors. So this increased gastric pH can inhibit the absorption of ceftiofurine, ceftriaxone, and ceftriaxone, and this will decrease the serum drug levels, decrease the efficacy of our cephalosporin. So a couple ways that you can mitigate this interaction. You can administer the cephalosporin 2 hours prior to antacids. Separating the doses may be somewhat effective with H2RAs and PPIs, but it will be less effective in separating the dose from antacids because of the duration of action. You can also consider an alternative cephalosporin. So only some agents in the class have this interaction, so we can use a different cephalosporin, and then as always monitor for reduced efficacy. So for carbapenems, they do have a class-wide interaction with valproic acid. So all of our carbapenems interact with valproic acid to result in reduced plasma concentration of valproic acid. So with a reduction in the plasma concentration, this could result in reduced seizure control, and seizures could develop. The mechanism behind this interaction is not fully understood. There are several different possibilities. The most commonly cited is a decrease in intrahepatic recirculation of valproic acid, but this mechanism is not fully understood, and it's likely multifactorial. So in this case, you can use alternative antibiotics. So we know that an adverse effect of carbapenems is that they also lower the seizure threshold. So if we're using drugs that lower the seizure threshold and then they're interacting with a medication that treats seizure, prevents seizures, then we have kind of two different things there that could result in poor seizure control. So using an alternative antibiotic could be effective. We oftentimes go to carbapenems because they're very broad spectrum, and we need something that broad to treat a resistant bacteria, for example. So we may not be able to use an alternative antibiotic, and in that case, we can monitor valproic acid plasma concentrations, and monitoring levels can be helpful in ensuring that we have adequate therapy. So this is everything for the beta-lactams. We'll move on to macrolides now, which have numerous drug interactions. So macrolides are 3A4 substrates and inhibitors. So you'll see multiple interactions with any 3A4 substrates. So clarithromycin and erythromycin have greater 3A4 inhibition than azithromycin does. So in a lot of the interactions that we've seen in other lectures with macrolides, the recommendation is to try to use azithromycin instead of the other macrolides when you're able to. But know that azithromycin still has this effect, but to a lesser extent than the other agents. So 3A4 inhibition will result in increased concentration of 3A4 substrates and toxicity. Macrolides are also P-glycoprotein inhibitors. So using them with P-glycoprotein substrates will result in increased concentrations and toxicity again. We know a lot of agents are substrates of both 3A4 and P-glycoprotein, so this can have a pretty significant effect when they're used with macrolides. Macrolides also can cause QT prolongation. So when using macrolides in combination with other QT prolonging drugs, it's important to be aware of this potential risk. So a couple specific interactions to point out. So our DOACs, the direct oral anticoagulants, so apixaban, dabigatran, edoxaban, rivaroxaban, all interact with macrolides through both the 3A4 and P-glycoprotein inhibition. So this will result in increased concentration of the anticoagulants and a risk of bleeding. So unlike warfarin, we can't monitor the levels of these agents, so the bleeding risk can be substantial, and we'll often try to avoid macrolides with these agents. So digoxin also interacts with macrolides through P-glycoprotein inhibition. This interaction in particular is seen to be more significant with clarithromycin than with the other agents, and it can be very significant, so up to a 4-fold increase in digoxin concentration, which can result in digoxin toxicity. And then finally, we've talked about the immunosuppressants previously, so our mTOR inhibitors and calcineurin inhibitors are both metabolized by 3A4 and PGP. So macrolides will inhibit this metabolism and increase the concentrations of our immunosuppressants. So with these agents, both the mTOR inhibitors and the calcineurin inhibitors, remember that we can monitor serum levels, and we do that routinely with our immunosuppressants. So that's one way to deal with the interaction. Would also want to monitor for toxicity. We didn't go over all of the interactions with macrolides in terms of 3A4. So these are things that you've seen throughout the course, but any substrates of 3A4 are going to interact with macrolides since they inhibit 3A4. So our next class are fluoroquinolones, and they have some similar interactions to the macrolides and are another class of antibiotics that have numerous drug-drug interactions that we have to watch out for. So ciprofloxacin is a 3A4 inhibitor. And all of these agents also cause QT prolongation. So again, we have to worry about extensive QT prolongation leading to torsades in patients on multiple QT prolonging drugs. Fluoroquinolones also interact with bi- and trivalent cations, which we'll talk about a little bit more. And they interact with corticosteroids. So the interaction with corticosteroids is due to additive toxicity. So both steroids and fluoroquinolones have a toxic effect on tenocytes, so the tendon cells, through different mechanisms. And so this additive toxicity will result in an increased risk of tendinitis or tendon rupture. And this interaction is seen even more so in older patients, so we think of greater than 60 years old, as well as patients with renal insufficiency will have a greater likelihood of adverse effects with combining corticosteroids and fluoroquinolones. So we'll often try to avoid fluoroquinolones in older patients because of this interaction and also because of some other just side effect profile of fluoroquinolones that are more significant with older age. So with our binding agents, the di- and trivalent cations, they bind fluoroquinolones and reduce the absorption. So this will result in decreased serum drug levels and decreased efficacy. So the best way to avoid this interaction is to use an alternative binding agent. You can also separate the agent, so give the fluoroquinolone 2 hours before or 6 hours after the binding agent. With our antacids, the calcium-based antacids have less of an impact than magnesium and aluminum-based antacids, but it's typically easier to just use a broader recommendation to separate any antacids from fluoroquinolones or to avoid using them. And then we can, as always, monitor for a reduction in efficacy. All right, so we're going through these quickly. Our next one are tetracyclines. So the two main interactions that we worry about with tetracyclines are two that we've seen before. So similar to some of our penicillins, tetracyclines can interact with oral contraceptives. So it's important to monitor to counsel patients to use an alternative form of contraception while they're taking a tetracycline and for the full cycle after completing the antibiotic. And tetracyclines also interact similarly to fluoroquinolones with our di- and trivalent cations. So same agents here, the interaction will decrease absorption, reduce our serum drug level, and reduce efficacy. And whenever we're reducing the efficacy of our antibiotics, that could lead to inadequate treatment of infection and the emergence of resistance. So certainly significant consequences there. How we deal with this interaction is the same as with fluoroquinolones. So we can separate the binding agents from the tetracyclines, give the tetracycline 2 hours before or 6 hours after the binding agent, use an alternative antibiotic, use an alternative binding agent, and monitor for reduced efficacy. So next we'll talk about sulfamethoxazole, trimethoprim, and Bactrim. So both components of this drug have drug interactions that we need to be aware of. And some of these interactions are a little bit different than some of the others that we've seen. So sulfamethoxazole is a 2C9 substrate and an inhibitor. And whenever I think 2C9, I think warfarin, right? Because warfarin is metabolized by 2C9, and we know that drug interactions there can be very significant. So sulfamethoxazole, think 2C9, and then trimethoprim acts as a potassium-sparing diuretic. So it has some interactions with that, and it also inhibits glucuronidation. And this is an interaction that we've seen previously with our immunosuppressants. So we'll look at sulfamethoxazole first, and then some with trimethoprim as well, and have some specific drugs listed here. So as we said before, warfarin is metabolized by 2C9. Just sulfamethoxazole will inhibit 2C9, and this will cause an increase in INR that could result in bleeding. So careful monitoring of warfarin is very important. If a patient has to receive sulfamethoxazole, it's better to avoid this antibiotic when possible and use a different antibiotic. 2C9 inhibition also causes an interaction with some anti-diabetic agents that are metabolized by 2C9. So sulfonylureas, so glipizide, glyburide, glimepiride are sulfonylureas. Nitaglinide, rosiglitazone are all metabolized by 2C9. So inhibiting 2C9 could result in increased plasma levels of the anti-diabetic agents and a risk of hypoglycemia. And this could be very significant. I've seen actually a patient admitted to the ICU who was on a sulfonylurea, I believe they were on glipizide. They received an interacting drug and ended up in the ICU because of hypoglycemia. So it can be very significant. Sulfamethoxazole and trimethoprim can interact with methotrexate, again at the larger cancer doses, not at doses that are used for other indications. So this is due to inhibition of renal tubular secretion and can result in methotrexate toxicity. So with the methotrexate toxicity, the main things that we worry about that we'll see are bone marrow suppression and GI toxicity. 2C9 inhibition also causes an interaction with phenytoin. So sulfamethoxazole inhibits 2C9. This can result in phenytoin toxicity. Main toxicities that you'll see are some changes with vision, so diplopia, nystagmus, it can lead to lethargy, confusion, and even as with severe toxicity, coma. So phenytoin toxicity can be significant as well. The interaction with procainamide is due to the trimethoprim component of Bactrim. So trimethoprim inhibits renal tubular secretion, and this can result in procainamide toxicity. And the main toxicity that we'll worry about here is QT prolongation. Dofetilide, 70% of dofetilide is eliminated unchanged renally. And so trimethoprim competes with dofetilide for cationic tubular secretion, which would result in less elimination of dofetilide, so a higher serum concentration, so toxicity. And with dofetilide, again, the main adverse effect that we'll see here is QT prolongation. And finally, zidovudine, we've seen before when we talked about antiretrovirals. So zidovudine is one of our NRTIs, the nucleoside reverse transcriptase inhibitors. And if you remember, the NRTIs have fewer drug interactions than the protease inhibitors and the NNRTIs. But zidovudine was one that does have an interaction because it undergoes glucuronidation. And trimethoprim inhibits glucuronidation, and this can lead to zidovudine toxicity. So we talked about NRTIs having some class-wide adverse effects. With zidovudine, one in particular that we worry about is anemia. So this interaction could lead to significant anemia due to zidovudine toxicity. So the other interaction that we'll talk about with Bactrim is specifically with trimethoprim, and this is due to its action as a potassium-sparing diuretic. So trimethoprim interacts with ACE inhibitors, as well as our potassium-sparing diuretics, so spironolactone, triamterene, eplerenone, amiloride, due to additive toxicity. So both the trimethoprim and these other agents can cause hyperkalemia. So when we use the agents together, we could get a significant hyperkalemia that could lead to arrhythmias or even as significant as cardiac arrest. So this is a class 2 interaction. One thing that we can definitely do is to monitor serum potassium levels, and that can be helpful. And we also want to avoid things that have additive toxicity. So there's a list of drugs here that could also cause hyperkalemia, so we want to avoid these combinations. We'd also want to be sure to avoid a potassium-rich diet. Patients with renal insufficiency could have a higher risk of hyperkalemia. Patients taking potassium supplements. Or sometimes we have to also think about salt substitutes can be high in potassium. So any other agents or conditions that could put a patient at risk of hyperkalemia, you want to be especially careful to avoid these interactions. All right, so moving along, our next agent is metronidazole. And metronidazole has several interactions due to 2C9 inhibition. So these interactions are similar to what we saw with sulfamethoxazole, since it also inhibits 2C9. So the combination with warfarin will result in an increased INR, risk of bleeding. The combination with sulfonylureas, metiglonide, or glitazone will result in hypoglycemia. And the combination with phenytoin can result in phenytoin toxicity. So these are the same interactions that we saw with sulfamethoxazole due to the 2C9 inhibition. We've also seen the interaction previously between metronidazole and mycophenolate. So this is again because of inhibiting the intrahepatic recirculation. So it prevents the conversion of an inactive mycophenolate metabolite back to the active mycophenolic acid. So we have a reduction in serum level and reduced efficacy of mycophenolate. And so with reduced efficacy of our immunosuppressants, that could lead to rejection in a transplant patient. So linezolid has an interaction that's from a unique mechanism compared to our other agents. So linezolid functions as a weak, non-selective monoamine oxidase inhibitor. So when we use linezolid in combination with serotonergic agents, this could result in the risk of serotonin syndrome. Serotonin syndrome is just essentially a reaction to having too much serotonin, and it's characterized by mental status changes. Sweating is very characteristic, hyperreflexia, hypothermia, diarrhea, tremors, muscle rigidity, and can lead to coma as well. So we worry about this with other serotonergic agents. So tricyclic antidepressants, particularly clomipramine and imipramine, are serotonergic. And then our SSRIs and SNRIs are also serotonergic agents. So this combination could result in serotonin syndrome. So this comes up relatively frequently in practice because patients are usually on antidepressants for an extended period of time, and linezolid is typically a short course. And so it will often be questioned whether or not this interaction is significant enough that we need to stop the antidepressant during the linezolid therapy, or if it's okay to continue them. And you'll see different things in practice. The recommendation is to only use the two if the benefit outweighs the risk. So if a patient if there's a way to use a different agent, then that would be preferable. So with our tricyclic antidepressants, there are some agents, amitriptyline, doxepin, desipramine, that have less serotonergic effects than the clomipramine and imipramine. So if it's feasible to use a different agent, then that would be wise, or to use a different antibiotic. So tadizolid, vancomycin, some of our newer MRSA agents like telavancin don't have serotonergic activity, so they would not have this interaction. But a lot of times we're using linezolid because our other agents aren't an option. So if you have the option of vancomycin or linezolid to treat an MRSA infection, you're typically going to choose vancomycin unless there's some reason they can't have it. So maybe there's a high MIC, or the patient's tried vancomycin and they've failed therapy, or they've developed severe nephrotoxicity. So there's some instances where we can't use vancomycin, and we're using linezolid for that reason. If it's just for a short duration, for a 7 days or just a few days, many practitioners will continue both of the agents together, because by the time we stop the antidepressant, it's going to take a few days for the effects to fully wear off, and then we're about done with our antibiotic anyways. But if you're using linezolid for a longer course, so sometimes you may need a long treatment for like an infection in the bone or a severe skin and soft tissue infection, if you need a longer course of treatment, then it might be a good idea to stop your antidepressant and then monitor for the symptoms of serotonin syndrome. Linezolid also interacts with indirect sympathomimetics. So due to the MAO inhibition, this can cause an increase in the pressor response to sympathomimetics. So if we look at our sympathomimetics, all of these agents will raise your blood pressure, and using them in combination with linezolid can result in a little bit higher increase in blood pressure. So it could cause hypertension. So with some of these agents, that's okay. If the patient's on phenylephrine in the hospital, we're using that because they're hypotensive and we want to raise their blood pressure. So if they need linezolid and they're on phenylephrine, I'm not going to be worried about this interaction because linezolid is helping us to raise their blood pressure. But some other agents, so amphetamine, pseudoephedrine, methylphenidate, if a patient's using these agents and maybe already has a history of hypertension and then we add linezolid, that could result in increased blood pressure and potentially worsen their hypertension. So the recommendation here is to use an alternative antibiotic when possible, and then to monitor blood pressure, monitor for fever, seizures, arrhythmia. But again, depending on the agent, it may be helping the effect of that agent, so particularly with phenylephrine. All right, so next up are the azoles. And you've seen these probably in almost every class period so far, I would guess, because there are a lot of interactions that we worry about. So all of our azole antifungals inhibit 3A4. Itraconazole, ketoconazole, and posaconazole have a stronger inhibition of 3A4 than fluconazole and voriconazole do. So if you have an interaction due to 3A4 inhibition and it's possible to change to fluconazole, then that would be advisable. Sometimes we need the other agents because fluconazole is not effective. But when you can, changing to fluconazole is helpful. Fluconazole and voriconazole also inhibit 2C9 and 2C19. So again, when we see 2C9, we think warfarin, right? And then our other azoles also inhibit P-glycoprotein. So there are a lot of enzymes that are inhibited through azoles, so a lot of interactions that we have to be aware of. So enzyme inducers will enhance the metabolism of azoles, which will decrease the serum drug levels and decrease their efficacy. But when we're using enzyme inducers, many of these are also substrates of the same enzymes, so the azoles will decrease the metabolism of those inducers through inhibition. So we'll have increased serum drug levels and toxicity from the inducers, but we'll have decreased serum drug levels and loss of efficacy with the azoles. So fluconazole is less susceptible to enzyme induction than the other agents, which is due to its primarily renal elimination. But in these cases, we can consider increasing the azole dose. It's also important to monitor for loss of antifungal efficacy and also monitor for toxicity with our enzyme inducers. Gastric antisecretory agents can decrease the absorption of some azoles as acidity is required for absorption, so this will decrease our drug levels, decrease efficacy. So fluconazole and voriconazole are less susceptible to this. So again, we can try to use an alternative azole. Something unique here is that only some of the dosage forms are susceptible to this interaction. So the itraconazole solution and the posaconazole delayed release tablet are not affected by gastric pH. So if it's possible, if someone has a patient that needs itraconazole and they're also on a proton pump inhibitor, then avoiding the solution and using the tablet could be helpful to reduce this interaction. It's also recommended to administer these azoles with Coke or Pepsi to improve their absorption. So if a patient's on itraconazole, we'll commonly counsel them to take it with a Coke, and that will help with absorption because of the acidity. So it's not very often that we recommend Coke and Pepsi with medications, but this is one instance where we can. You can also consider increasing the azole dose. So gastric alkalinizers, antacids, didanosine, sucralfate have the same interaction as the H2RAs and PPIs. So this decreased absorption can lead to decreased serum drug levels and decreased efficacy. So the way that we deal with this is the same. We can use fluconazole instead. We can use our specific dosage forms of itraconazole and posaconazole that aren't affected by gastric pH. And then with antacids, it's easier to separate the doses. So we can give the azole 2 hours before or 6 hours after the antacids. Okay, so a little bit more with azoles. So they have the same interactions that we've seen with their other 2C9 inhibitors. So this is specifically fluconazole and voriconazole that inhibit 2C9 and 2C19 in addition to 3A4. So we'll see the same interactions with warfarin, with sulfonylureas, and with phenytoin and inhibiting 2C9 that can result in toxicity from these agents. All right, so the next class that we'll talk about has probably even more drug interactions. So these are our anti-tubercular drugs. So for tuberculosis, we will typically, the go-to treatment is RIPE therapy, so rifampin, isoniazid, pyrazinamide, ethambutol. And we see that both rifampin and isoniazid have significant drug interactions. And they're different drug interactions. So isoniazid is an inhibitor of 3A4 and 2C19. Rifampin is an inducer, so it induces multiple cytochrome P450 enzymes as well as P-glycoprotein. Rifabutin is another rifamycin that's sometimes used as an alternative to rifampin. It's an inducer of 3A4 that doesn't have as widespread induction as rifampin does. It's also a substrate of 3A4, which is different from rifampin. So rifabutin will be affected by other 3A4 inhibitors and inducers. Beta-qualine isn't used routinely for TB treatment, but it's used to treat multi-drug resistant tuberculosis. So you don't see it as frequently, but it is a substrate of several cytochrome P450 enzymes, so there are several interactions that are important there as well. You'll see that our interactions with rifabutin and beta-qualine are similar because they're both substrates of 3A4. So we'll have some similar interactions with 3A4 inducers and inhibitors. So isoniazid, rifampin, and rifabutin can increase the formation of toxic acetaminophen metabolites. So this results in both reduced analgesic effect and hepatotoxicity. So if a patient's on one of these agents and acetaminophen together, it will typically be recommended to not use more than 2 grams of acetaminophen a day. So with our interaction with apixaban and rivaroxaban, isoniazid is an inhibitor, so it will result in increased anticoagulant concentrations and bleeding. But rifampin and rifabutin are inducers, so they'll result in decreased efficacy. So it's recommended to avoid apixaban and rivaroxaban with rifampin or rifabutin. You should not use this combination together. If a patient required rifampin for treatment of tuberculosis, and they were also on apixaban, for example, we would stop the apixaban and change to warfarin for that time period. So isoniazid as a 3A4 inhibitor can interact with some of our anti-diabetic agents also. But take note that these are different anti-diabetic agents. So the ones we talked about previously, like sulfonylureas, are metabolized by 2C9. Niteclonide is the only one that you'll see in both of these groups. So niteclonide is metabolized by 2C9 and 3A4. But pioglitazone, saxagliptin, sitagliptin, these are different anti-diabetic agents that interact with isoniazid, and the same effect would be present as hypoglycemia. So a few more interactions with our anti-tubercular drugs. So as a 3A4 inhibitor, isoniazid and carbamazepine have a pretty significant interaction. This results in significant increases in carbamazepine levels and toxicity. So carbamazepine toxicity, you'll typically see initially nausea, vomiting, dizziness, can lead to confusion and altered mental status. Isoniazid also interacts with clopidogrel due to 2C9 inhibition. So this inhibits the conversion of clopidogrel to its active metabolite. So even though it's an inhibitor, we'll have reduced activity of clopidogrel because we're going to have more of the inactive prodrug and less of the active metabolite. The interaction with phenytoin will be opposite effects with isoniazid and rifampin. And this interaction is with multiple cytochrome P450 enzymes. So isoniazid inhibits 2C19 and 3A4, which phenytoin is metabolized by, and rifampin induces 2C9, 2C19, and 3A4, which phenytoin is metabolized by. So typically, isoniazid and rifampin are used in combination as part of our RIPE therapy. When they are used in combination, even though we have these competing interactions that in some ways counteract each other, the rifampin interaction clinically outweighs the isoniazid interaction. So we'll see more induction than we do inhibition. So that will result in decreased phenytoin concentrations and decreased efficacy. If someone needs phenytoin and is on RIPE therapy, we can monitor phenytoin levels and adjust our dose. Or if you can use an alternative anticonvulsant, that would be preferred. All right, so I mentioned that some of our interactions with rifabutin and beta-quilene will be similar because they're both 3A4 substrates. So these are similar interactions that we've seen before with other 3A4 substrates. You don't see this interaction with rifampin because rifampin is an inducer of 3A4, but not a substrate of 3A4. So some of our antidepressants, fluvoxamine and nifazodone, are 3A4 inhibitors, so we'll have decreased metabolism of rifabutin and beta-quilene, increased serum drug levels, and increased toxicity. So we can use an alternative antidepressant. We can consider reducing the dose and then monitor for toxicity. So the main toxicities that we'll see with rifabutin are uveitis, so that's an inflammation of the middle portion of the eye, rash, bone marrow suppression, and hepatotoxicity. With beta-quilene, the main toxicities that we'll see are, again, hepatotoxicity as well as QT prolongation. So our antimicrobials that inhibit 3 and 4 are ones that we're talking about today, but they have this specific interaction with rifabutin and beta-quilene. So our macrolides, azoles, and fluoroquinolones all inhibit 3A4. So this will result in decreased metabolism of the anti-tubercular agents. Rifabutin, since it's also an inducer, will induce the metabolism of our antimicrobials. So we'll have increased serum drug levels and toxicity of our anti-tubercular agents, and we'll have reduced serum drug levels and reduced efficacy of antibacterials. That's just with rifabutin because beta-quilene is not an inducer, it's just a substrate. With our enzyme inhibitors in general, we will similarly see a reduced metabolism of rifabutin, and with rifabutin we'll have an enhanced metabolism of those enzyme inducers. So again, we'll have toxicity with the anti-tubercular agents, and we'll have loss of efficacy with our enzyme inducers. Beta-quilene is more susceptible to enzyme inducers than rifabutin is. So with enzyme inducers, we'll have increased metabolism of beta-quilene and reduced serum drug levels and efficacy. So some of our common enzyme inducers are anticonvulsants. So with beta-quilene, you should avoid barbiturates, carbamazepine, phenytoin, and may consider something like levetiracetam instead. For antiretrovirals, we talked about how many of these are enzyme inducers. So our protease inhibitors and non-nucleoside reverse transcriptase inhibitors have the main interactions. This is a typo here. So we should use NRTIs when possible, not NRTIs. So protease inhibitors and NRTIs are the inducers. They have the main interactions. NRTIs have fewer interactions. So make sure you get that corrected on your slides, that the antiretrovirals, we want to try to use NRTIs when possible. All right. So the last class that we'll talk about are antiparasitic drugs. So these are drugs that are used to treat malaria. Some of them also have other uses. So hydroxychloroquine, in addition to being an anti-malaria drug, is also used for lupus as well as arthritis. And you'll probably see it, we don't treat malaria that frequently, but you will see it relatively frequently for lupus and sometimes for arthritis. And then quinidine is an anti-malaria drug, but it's also an antiarrhythmic. So we see that all three of these agents are 2D6 inhibitors. And quinidine has some additional interactions because it's also a PGP inhibitor, and it's a 3A4 and a PGP substrate. And as an antiarrhythmic, we're not surprised that it can cause QT prolongation. So all three agents, chloroquine, hydroxychloroquine, and quinidine, interact with iotidine through 2D6 inhibition, and this can result in QT prolongation. As a PGP inhibitor, quinidine also interacts with our direct oral anticoagulants, So it inhibits P-glycoprotein, which would result in increased serum levels and the risk of bleeding. And then chloroquine, hydroxychloroquine, and quinidine all interact with digoxin. So the mechanism here is thought to be through PGP inhibition. However, we saw in the previous slide that only quinidine is really a PGP inhibitor. So the mechanism behind chloroquine and hydroxychloroquine is not as well understood. But clinically, there's an increase in digoxin levels that can result in digoxin toxicity. All right, so those are all the agents that we talked about. That was a ton of information, so I'm going to try to group some of these together so that we can think about classes that have similar effects. So our 3A4 inhibitors and inducers. So macrolides, fluoroquinolones, azoles, and isoniazid are all 3A4 inhibitors. So with our macrolides, we think of azithromycin having less of a strong effect on 3A4. And with fluoroquinolones, we primarily think of ciprofloxacin. And with azoles, fluconazole has less of an effect. So if you have to use these antimicrobials with 3A4 substrates, you'd want to choose azithromycin over the macrolides and fluconazole over the other azoles. And you'd want to choose an alternative fluoroquinolone. So levofloxacin or moxifloxacin would be preferred over Cipro. Our inducers of 3A4 are rifampin and rifabutin. So whenever we see the rifamycin, think induction. Rifabutin induces 3A4, and rifampin has more of a wider induction pattern. It induces multiple enzymes. So we've talked previously about different 3A4 inhibitors, inducers, and substrates. This is not a complete list, but I wanted to at least provide you with a partial list of some of the more common agents that you'll see here, because we've talked about these interactions so frequently. So our 3A4 substrates, we have to worry about all those inhibitors on the previous slide. So ones that you'll see frequently are calcium channel blockers. Now remember that verapamil and diltiazem are 3A4 inhibitors. Our other calcium channel blockers are not inhibitors, but they are substrates of 3A4. So when we had these interactions before, we said that amlodipine might be preferred over verapamil and diltiazem. That's true, but amlodipine is still a 3A4 substrate. So when we use, for example, an azole with amlodipine, we'll still see inhibition of 3A4, so we'll see inhibited metabolism and increased levels of amlodipine. Many antidepressants are 3A4 substrates. Our direct acting oral anticoagulants are 3A4 substrates. The NNRTIs and PIs, so our two classes of antiretrovirals that have a lot of interactions, are substrates. They're also, many of them are inhibitors, and some of them are inducers. Statins are big agents that we've talked about here. Corticosteroids are immunosuppressants we've talked about previously. Proton pump inhibitors, a lot of antipsychotics and antiarrhythmics and opioids are all 3A4 substrates. So whenever we think about our 3A4 inducers and inhibitors, we should keep all of these agents in mind. Okay, so we also talked about several classes that inhibit or induce P-glycoprotein. So our macrolides, azoles, and quinidine all inhibit P-glycoprotein activity, and rifampin induces P-glycoprotein. We've also talked about several agents that have QT prolongation. So macrolides, fluoroquinolones, and quinidine are all antimicrobials that cause QT prolongation. I know you've talked about QT prolongation previously in this course and talked about other agents. So when we're looking at the antimicrobials here, you'll also want to be aware of other common agents that can cause QT prolongation. So antipsychotics, some antidepressants, other agents. Okay, so this is very busy, and I'm not going to read through all of it, but this is an attempt to put the main considerations and the main interactions for each of these classes on the same slide so that you can try to compare them and find similarities and differences. So, for example, penicillins and tetracyclines both have the oral contraceptive interaction. Tetracyclines and fluoroquinolones both interact with di and trivalent cations. So this may or may not be useful to you. If it's too overwhelming, then just skip it because all the information is in the other slides. But this may help you to kind of group some of these interactions together and find similarities and differences between some of these agents. So in general, with antimicrobials, there's a lot to keep in mind because our antimicrobial course is often for a short duration of therapy, whereas some of our other drugs that interact with them are more maintenance medications that will be continued sometimes indefinitely. So even though antimicrobials are for a short duration, this doesn't mean that we can ignore their interactions. Some of them are really quite significant and would warrant either an alternative therapy, a change in dose, or a change in our monitoring practices. It's also important to understand the effects of these interactions when you're starting the antimicrobial and when you're discontinuing it, and to keep in mind that these effects might not happen immediately. So it may take several weeks to see the full effect when you start the antimicrobial. It may also take several weeks to have that effect fully wear off when you discontinue it. So it's important to understand those implications. And if you did, for example, change the dose because of the interaction, then you'll need to be aware of when you need to change the dose back to the original dose. It might not be the same time as when you stop the antibiotic. Our macrolides, fluoroquinolones, and azoles all inhibit 3-4, so these are particularly prone to drug interactions. Some of the other classes of antibiotics have different interactions through different mechanisms that aren't quite as common. So that was a lot of material. That's all of the material for today. Are there any questions right now? So we're going to spend, so remember we're meeting tomorrow instead of Thursday. So we'll have class tomorrow at 12:15 instead of Thursday. And we're going to spend the whole class period going through the cases that are posted on ELC. And these cases hit most of the classes of antimicrobials that we've talked about. And then we'll also go through just some practice questions with the antimicrobials, and may throw in a few questions from the other lectures on antiretrovirals and immunosuppressants to kind of put all this together and make sure you start to feel comfortable with the interactions, because I know there are a lot of them, particularly in this lecture. So we finished a little early, but be ready tomorrow if you want to look at the cases beforehand. That might be helpful. I'll give you some time in class to work with people around you, but we want to have a good discussion, and really I want you to feel confident in these interactions when we leave tomorrow. So any questions? All right. Well, thank you. I'll see you tomorrow. Any announcements, Dr. Duke?
I'll have some for tomorrow, but I do want to just emphasize something that you stressed several times today. All these interactions have come up multiple times this semester. We've talked about these things as object drugs, we've talked about them as precipitate drugs, and so hopefully that's going to actually make it easier to study for the comprehensive portion of this, because you can't, these aren't a bunch of silos we're talking about. We're looking at the whole farm here of all the interactions. So, and that's the point, and again, I appreciate Dr. Smith bringing that out today. The way this course was taught this time by topic rather than just by drug, these have all come around several times, and the idea is to make it get deeper into your head, and also make it easier to prepare for the exam, but also to carry that with you on rotations next year. And oh yeah, that other exam, you'll have it in your head for those too. So I'll see you all, talk to you tomorrow, and give you more information as far as the composition of the final. Thank you, Dr. Smith.
Thank you.